If you're going to get a vaccine, one could argue that it's very beneficial to understand what is actually happening within your body, the types of vaccines that are available to you, and the differences between them from an efficacy standpoint, side effects standpoint, and general quality. And so we're going to go through right now. Majority of people watching this, you're going to get the vaccine or you've already got it. Shouldn't you know how it works? Shouldn't you know what's going on inside your body? It could be valuable to know how the differences between different vaccines can change the efficacy and the immune response and the side effects potential. And it can be very valuable to understand what's going on inside the body. And the vaccine that you may have gotten may not have been the most efficacious one. So I'm going to go through a bit of an extensive video that I'm going to chop up and distribute about the COVID vaccine, different types of vaccines and their efficacy, side effects. And we're going to begin with the interesting fact that as of June 15th, guess how many people have been vaccinated? It's a staggering number globally so far. We've had 733 million people worldwide fully vaccinated. That's nearly 10% of the worldwide global population. 2.2 billion doses of the SARS-CoV-2 vaccines have been administered since June 14th. This is from the World Health Organization, purported through Johns Hopkins. And the US, which was a big epicenter for a lot of this, actually 311 million administered so far, which is, again, a very large amount. Over 50% of the US population have had at least one dose of the vaccine. So we're going to see some interesting things over the next months and years to come. Well, side effects? Well, we're going to see, at least from an epidemiological perspective, on what will manifest, because there is no free lunch. There is consequences and potential consequences to everything, whether that's building antibodies against the virus, or whether that's a subset of a population receiving unfortunate detrimental side effects. So first of all, you've gotten the COVID vaccine, or you're going to get it. What type of vaccine did you get? Did you realize that there are multiple different types of vaccines? There's an mRNA vaccine, there's an adenovirus vaccine, there's a protein vaccine by Novavax, which actually isn't out yet as of making this anyway. If you've gotten any number of these vaccines, let's go through what they are, the differences between them, and their efficacy differences. So, because the mRNA technology is the new technology that enabled us and the world to get this out so quickly. A lot of this information that I'm purporting is from Dr. Roger Schwelt. He is a quadruple board certified internal medicine physician. Actually, he's in pulmonary disease, sleep medicine, and internal medicine, as well to treating patients and teaching medical classes, and actually running one of the biggest YouTube channels on medicine called Medicram. So pretty damn knowledgeable guy, but it doesn't really matter. Everyone has their guy or girl that they're going to purport as an authority. That is the reason why you should believe what they're saying. Critically think on your own, laterally think, get multiple sources. But a lot of the stuff I'm going to be reporting is from him, Dr. Rhonda Patrick, World Health Organization, Johns Hopkins, and a couple of various research studies that will quote. Why are these vaccines able to be rolled out so quickly? It's a natural, healthy concern of us, and I think it's very reasonable and rational to have some concern and some skepticism, or just let's see how this works. That's a pretty rational response, because there's a lot of things we don't know about, and we're not going to know until we get a longer time point, until more people are immunized, vaccinated. But so far, everybody doesn't seem to be turning into green aliens who are diseased and dying. It seems to be pretty safe so far from a statistical standpoint of side effects and efficacy of building the antibodies. Like, is it doing what it's supposed to be doing? So far, in the majority of people, it seems to be that way based off a lot of the research, okay? And we'll quote some of that research. We're not just going to say it. We're going to quote it, and we're going to pick it apart a little bit. However, we need a more longer time point because, there are some concerns about long-term side effects of vaccines, which I'll talk about later on. But why are these vaccines able to be rolled out so quickly? So I'm going to quote Dr. Roger Schwelt. And so we have traditionally conventional vaccines. They typically take a long time. And the problem is we're comparing conventional vaccine times to our mRNA vaccine rollouts, which are different technologies, mRNA being quite new and very innovative and just different enough, which enables us to speed up the process of manufacturing and distribution. So conventional vaccines, where they actually inject the protein into the cell, the reason why they're probably taking that long is because it takes a long time to actually make that protein. There's a lot of regulation that goes into it. That's why these vaccine companies who choose not to use mRNA, they go the conventional route, they take a long time. So in the past, it took a long time to make vaccines because a lot of regulation, and they have to make sure everything's quote unquote purified, and it takes a long time to make the protein. So now what Moderna and Pfizer are doing, what AstraZeneca are doing, is that they're kind of moving this factory production point and putting it into your body. So the body's now making the protein instead of the protein being made outside of the lab. And it's able to be made because it's an mRNA vaccine, which is it's the mode of transport which it gets into the body. The mode of transport between the main differences between all these vaccines is the mode and vector of transportation into the body to elicit the immune system response. We'll go through that later on some of the differences between those vectors. But because that main difference between one protein made in the lab, one protein is made in your body, is one reason why this can be rolled out a lot quicker. Of course, it is concerning where you think, oh, it's being rolled out quick. That can't be a good sign. Of course, in a global pandemic, things are going to be sped up, right? You could be concerned, will they cut corners and things like this? Well, we don't know all the intricacies of step 1 to step 100 of how this vaccine gets rolled out, and what it would look like in a normal, calm, setting, not having a sense of urgency. So, of course, it's rational to have a healthy concern towards this, but that's one main reason why these vaccines are able to be rolled out quicker. Now, are there long-term side effects to vaccines and this vaccine? What could they be? How will we know? Generally speaking, and this is from Dr. Roger Schwelt, 90% of the long-term effects usually pop up within the first month or two, okay? And we actually see that in a study by the Emergency Use Authorization of COVID Vaccines. This was a 2020 study by the New England Journal of Medicine. They quoted adverse events considered plausibly linked to the vaccination generally start within 6 weeks after the vaccine is given. 2 months of follow-up will provide time for potential immune-mediated adverse events that begin within this 6-week period to observe and evaluate. And we usually see that. If you actually read the studies, you'll see that they'll have this median observation period about 2, 3, 4 months post injection of the last dose, not only to see side effects, but to actually see are the antibodies are adequate antibody, like they want to measure the antibody response and in conjunction with the type of dose given. So we're measuring these things on a population level because these are important markers and metrics for us. So the good thing is in the majority of vaccines, we're usually going to see, like the first couple of months, we're usually going to see the majority of side effects come up or not. And next is, let's give an example of what happens when shit goes wrong, okay? Because there's examples of obviously long-term side effects are plausible because they're plausible, or they occur actually within the COVID vaccine, within actually getting the coronavirus itself. Without a vaccine, just if you get the virus, So what are the potentials to just get it without it? Well, right now, we don't know. We don't have enough time points. Like, there's just not enough data, not enough time. So we're going to see over the hundreds of millions, the billions of people right now who have been administered, we're going to start to see over the next 6 to 12 to 18 months some of these things. Now, what's an example of how this can go wrong? Well, there's an example in 2009, 2010. We had the H1N1. And that was a regular flu vaccine that was administered in Europe, and they did actually find an increased risk of narcolepsy in patients that were vaccinated with that type of vaccine. And the thought process here was that there was an immune response that cross-reacted with a portion of the brain that produces hypocretin, which is the basis for narcolepsy, which is a sleep disorder. And so that didn't happen in all of the patients, but it was substantially increased in the general population. So those are the types of things we want to be on the lookout for. We want to look out for autoimmune related conditions. Now, of course, that's a very broad spectrum, right? But we have to understand if we're stimulating an immune system response from manufactured proteins or products that trigger proteins to be made within our body, whether you get it from a virus naturally or whether you get it from a vaccine, there is risk in either case to have a cross-reacted immune response in either way. So, but what are the risks here? What are the risks of the vaccine versus COVID? In terms of COVID infections and vaccinations, your risk of getting post-infective autoimmune condition is probably higher in COVID if you would get infected versus getting the actual vaccine, because this is a concern people have. I've heard people talk about, well, blood clots. I don't want to risk getting a blood clot from the AstraZeneca vaccine. If you look at actually currently the statistics of how many people actually present with it, it's very, very low. And we'll talk about that later as well. However, the risk of getting blood clots from COVID naturally without the vaccine is much higher, and we'll talk about later in the long extended version of this video, unless you're watching it on YouTube, about that. So it seems, and I am just a vessel for information, an observer, a researcher, a scientist, a coach. I am not the expert conducting the research. I am the professional interpreting it, summarizing it, breaking the complex to simple to deliver it to you guys, because I really think that's important. That there's so much information out there. Can I just digest it from really high quality sources and give it to the world and make myself more informed in the process as well? I don't really care about the outcome. I have no agenda of the outcome. I just want to know what the best, most reasonable, rational, logical, healthy decision is for me and my family. That's it. So now I'm predisposed to finding the most accurate version of the truth instead of getting wrapped up in dogma or bias. And I'm not saying I don't have them, because everyone has them, but I'm saying I kill myself mentally to try and acknowledge them and manage them and mitigate them when we're talking about such serious topics where it's really people's health, life, death, and a whole global population. So please know I take it extremely seriously, and if I ever get something wrong or a bit off, or I make an error or of judgment or interpretation, I will stop, admit, recorrect, readjust, pivot, keep moving. Anyway, risks of COVID vaccine. So it seems that the risk of post-infective autoimmune condition is higher in COVID. That's what it seems like, okay? But you got to remember, you're going to make antibodies against multiple portions of the coronavirus. So your chances of getting an antibody that might be directed against something in your body is higher when you have more epitopes. Epitopes are antigens. Antigens are the things that are capable of stimulating the immune response and are needed to eventually build antibodies. You need to get the antigen, stimulate the virus, to build the antibodies. So that's why people do antigen tests. They want to see if you have the virus in your body. So if you get the coronavirus or a flu, you're going to make antibodies against multiple portions of the coronavirus. Now, so you're going to have a high chance of creating more epitopes, stimulating more of an immune system response, comparatively compared to if you were to get the vaccine, particularly the mRNA, you get a very specific portion of the SARS-CoV-2, which we know is the spike protein found in the mRNA vaccine. See those spikes on the you see those images of COVID, and you got those spikes on the top. It's not for show. Those are the spike proteins that kind of key and lock in. So, because it's so specific, the potential immune-mediated response comparatively to getting the virus from natural means is lower. I'm being very careful with my words. When we're making a statement, we always have to say compared to what. So I'm comparing these two variables. However, there's examples of immune responses as a result of infections that can happen rarely in people, and it will come up serious cases of people are going to die of COVID and people are going to die of vaccines. It's going to happen. People are going to die of flus and viruses, and people are going to die of vaccines. It's the nature of it, okay? And people are going to get serious illnesses like Guillain-Barré syndrome. Well known for people who get it's known people get it who get viral infections. It's an autoimmune condition. Antibodies attack your nerves. You get paralysis. You can't walk. You can't breathe. It's terrible. Okay? It's known to happen after natural infection, and it can also happen after immunizations. Both. It's probably higher in natural infections because of the previous things that we just talked about before, than it would be in immunizations. But when we're talking about a pandemic situation, we got to outweigh risks and benefits. And when we're talking about these rare instances will occur, and they're going to be on the news, and they're going to frighten people, and they're going to make it seem bigger than it actually is. But when we look at it, the totality of the population, we see often that things are being blown out of proportion, or they're misrepresented, or people are misinformed in some way, and they don't understand relative risk versus absolute risk and just basic research and statistics, which just kills me. I wish everybody could just do a little crash course on that, and we could all just stop getting sucked into headlines, and we could understand some basic science better, because the science informs our decision making and our health and life. So, risks versus reward. A lot of these scientists, a lot of these doctors, the majority of the population seem to be on the side that the benefits outweigh the risks, at least at this point, given the information we have. However, that may change. It may change. And I'm going to come back here, and if that changes, I'm going to come back here, and I'm going to say, this is what I said before, and this is what's changed. Again, I'm a vessel for information, and with no agenda to swaying people to one side. Let me present, you make your own decision. So those are some basic summary of the risks of a vaccine versus getting a virus, particularly COVID, that one should and could consider. Most Australians will get, or will have gotten already, the AstraZeneca vaccine. This AstraZeneca vaccine is not the same as the Pfizer. It does not have the same efficacy. It does not have the same mode of transportation into the body. And it's important to understand the differences between the two, because they can implicate different side effects, efficacy, immune-mediated responses, and general immunity. So, how does it work? We're going to go through that now. The main difference between the Pfizer and the AstraZeneca is the mechanism or vector which these vaccines induce an immune response. One, the Pfizer and Moderna, They use mRNA technology. New technology seems to be very effective, okay? At least from an efficacious standpoint, previous videos and research I've purported, we're looking at 95% efficacy. Now, we compare that to the AstraZeneca. We're looking somewhere around the 70 to 80% efficacy at building immunity against the coronavirus. Now, this is dose dependent. We're going to summarize later in later videos, but let's actually talk about what the hell is going on. What are the differences? You let someone put a vaccine in your body, shouldn't you at least understand what's going on? I believe in informing the population and informing myself before doing anything like this. So here it is. So the AstraZeneca, it actually uses a adenovirus, a chimpanzee adenovirus. And people think, what are you talking about, chimpanzees? We're Homo sapiens. Well, it's because humans haven't seen chimpanzee adenoviruses. And so we don't have we don't want to have a vector used in that situation that could be recognized by the immune system, because then our immune system would destroy that vector before the actual message gets into the cell. Adenoviruses get into the cell. mRNA, it creates and triggers it sends the instructions, like an envelope, it sends the instructions to the body to make the protein to then build immunity inside the body. Just a 2-sentence, little quick difference. We'll go more into the differences later on, maybe in future videos or later on in this video. So, in this case, with the chimpanzee adenovirus, the message is not mRNA like here it is in Pfizer and Moderna. It's actually DNA. And so, the DNA goes into the nucleus. mRNA, as far as I'm understanding, which I'm very certain is correct, does not enter the nucleus. Now, so there's differences between the transmission and vector to which they get into the body. So DNA goes into the nucleus in the AstraZeneca. That's where it's transcribed into mRNA to provide the instructions and build that immune system response, build antibodies. The rest is the same from there. So it was. So it uses a replication. The AstraZeneca uses a replication deficient chimpanzee viral vector, which is the carrier of how it gets in the body. It's based on a weakened version of the common cold virus, adenovirus, that causes infections in chimpanzees and contains the genetic material of SARS-CoV-2 virus spike protein. After vaccination, the surface spike protein is produced, priming the immune system to attack the SARS-CoV-2 virus if it later infects the body. So now you've primed the immune system to understand the language of how to destroy a potential pathogenic virus. So, little summary right there on the difference between the AstraZeneca vaccine or the adenovirus and an mRNA vaccine, Pfizer. Lastly, to talk about side effects, because that's important. March 2020, several European countries actually paused the use of the AstraZeneca COVID vaccine after reports of blood clots. Clots linked to this vaccine have very specific characteristics. Although this is a serious event, it's also important that we look at context and relative risk. 20 million doses of AstraZeneca vaccine have been given in the United Kingdom as of March. I believe the risk of a serious blood clot was about 1 in 250,000, or 4 in a million. We got to compare. If we compare that to the COVID-19, carries a much higher risk of blood clots because we now believe it seems to be a vascular disease. We used to think of it as a respiratory disease. Now it seems to fit more of the mold of a vascular disease. Vascular inferring the system that transports blood. So COVID-19 carries much higher risk of blood clots. Around 7.8% of people who have had COVID-19 also have pulmonary embolism, and 11.2% experience deep vein thrombosis. That is from arterial and venous thromboembolism in COVID-19. That's a meta-analysis posted by TAN. It's available to the public for free in 2020. So you can look at that yourself if you want. So again, comparing the relative risks associated with AstraZeneca versus a Pfizer. Pfizer does seem more efficacious. They both carry their risks. They both have different modes of transportation. However, the outcome of building an antibody and immunity, or like at least temporary immunity, because immunity wears off, antibodies wear off, eventually, is different and should be considered when making your decision of which vaccine is the right fit for you. So if you've gotten the Pfizer vaccine, you are one of the fortunate people who have actually got a generally more efficacious vaccine as of right now compared to the adenovirus, AstraZeneca, or Johnson & Johnson vaccine. Now, when we look at that, you can see other videos I've made on comparing those two. However, let's see how it works. Like, what is an mRNA vaccine? What is it doing? How is it working? How is it different from an adenovirus AstraZeneca vaccine? So briefly, Pfizer, Moderna, they're the two companies that have propagated America and available as vaccines in America. So they rely on a pretty recent, and what a lot of scientists are excited about, this new innovative vaccine technology that uses the exploitation of RNA or mRNA as a viral vector, which means the transportation mechanism of how it gets in the body. And this has really opened the doors for vaccines to be developed, mRNA vaccines to be developed for many other diseases, including the flu, cancer, malaria, which, if it's effective more than it's risky, is great news, because these plague all of us in some way in every country. So let's go through how an mRNA vaccine works. How does the Pfizer vaccine that you put in your body, or you're going to put in your body, what's it doing? Shouldn't you know? It's probably good to know to be more informed as a human being and individual on the effects it could have in your body. So, mRNA. This is different from the AstraZeneca. Let's be very clear. The AstraZeneca is a chimpanzee adenovirus vaccine that has a different mode of transportation than an mRNA vaccine. So, Dr. Roger Schwelt did a really good job at summarizing, like in layman's terms, and I'm going to kind of steal his analogy. mRNA, it's like an envelope with a message in it. That message is going to tell the cell what kind of proteins to make. When you get the coronavirus, or any other RNA virus, that fuses with your cell, and whether it's in the cells in your nasal mucosa, another mucous membrane, it fuses. It tells those cells to make foreign proteins. We need to create proteins to build up immunity and antibodies. And so, in that sense, with the mRNA, we're doing that. We're just doing it in a different way that doesn't cause more viruses to be made. So when you get infected with a virus, the virus tells the cells to make more of everything. It's not indiscriminate, but it's exposed to more epitopes, which are basically the antigens, which produce the immune system response. RNA, on the other hand, makes viral proteins that are specific to the mRNA vaccine being given. It's only telling your cell to make a portion of the protein which we want the immune system to recognize, so that it ever comes around again, immune system is ready to mount a response, prevent it from invading your body. So people are like, oh, put this mRNA vaccine in my body, it's going to hang around and cause havoc. Well, the way mRNA technology, and not even technology, the way it functions is it's not going to stick around in your body. Like, even if it were, because it's like an envelope, it delivers and then it's gone. And how it goes is, like, even if it was to hang around, the purpose of the immune system is to find these cells with this foreign mRNA, because it makes proteins that are foreign, and to destroy those cells. So they're going to be destroyed anyway, even if they were to stick around. Now, let's keep going. mRNA. We didn't actually even cover what it is. It's a single-stranded molecule that mirrors the sequence of one half of a DNA strand. It plays vital roles in biology because it facilitates protein synthesis. Protein synthesis. Say that 10 times in a row. As a delivery mechanism for genetic instructions carried in your DNA. So we're sending those instructions to our body to make a protein to build immunity to a virus. So mRNA, they contain genetic instructions for the synthesis of a viral protein. I actually just did a pretty good job at summarizing that. There you go. When injected into the body, stimulates the immune system to make antibodies against the specific target. In this case, remember those spiky proteins you see on those images online? That's what we're making the immunity against. That spike is a glycoprotein. The glycoprotein is it's like a lipid molecule with protein in it that uses protection to transport into the cell. mRNA is fragile, so it needs these nanoparticles to protect it. And when it's actually injected into your muscle, it's taken up by the muscle cells. The muscle cells transcribe the mRNA to produce the spike glycoprotein. Excuse me, let me just recorrect what I said. It's in a lipid nanoparticle, not a glycoprotein. It produces a spike glycoprotein, which stimulates the immune response, protecting the person from whatever virus, COVID-19. So this new mRNA technology allows rapid scaling of vaccine production and facilitates modification if the virus mutates significantly because the mRNA can't enter the cell's nucleus. So its concerns about its safety are generally lower than a adenovirus, than a typical conventional protein vaccine, okay? Because the mode of transportation is different. It triggers your body to make the protein instead of the protein being made outside in a lab, which then enters your body, then triggering the response. So that's some basic differences in how one enters the cell. mRNA can't enter the cell. Side effects, it's important. There's no free lunch. Side effects are possible anywhere from a virus to a vaccine. Most reactions to the vaccine have been considered mild to moderate in severity. Data from one of the clinical trials showed that the most severe events after the first dose included injection site pain, 2.7%, fatigue, 9.7%, muscle pain, 9%, joint pain, 5%, headache, 4.5%, pain, 4%. This was the study called mRNA Vaccine Against SARS-CoV-2. It's a preliminary report, so I don't believe it's been peer-reviewed. It's important to consider. And this was published November 2020. And how many people did they use? 45. Okay, we conducted a phase 1 dose escalation open label trial, 45 adults. So this is an earlier study. Really, I shouldn't even be citing this because in other videos I've made on the Pfizer vaccine, I have cited studies much larger that demonstrate the Pfizer's efficacy to be quite, and its safety to be quite much more efficacious. If I can pull it up, I'll give you one right here. Safety and efficacy of Pfizer mRNA, December 2020. Clinical trial, 43,000 people, resulted in an efficacy rate of 95%, which is really important because AstraZeneca only has around a 79% efficacy, depending on the dose. Incidence of serious adverse events was low and was similar to in the vaccine and placebo groups. Moreover, CDC on January 6 reported 0.2% adverse effects of the Pfizer vaccine out of 1.9 million doses. That was in January 6, but that'll be updated by now, most likely. And so I'm just going off statistics. I think it's important to look at a whole range of data, collate it together, and not be married to one specific study, but look at where the totality of evidence is pointing. If it's inconsistent, that's not a good sign. If it's consistent and pointing in a direction, we can generally be more confident of a hypothesis and assertion and risk than not. So I've done other videos. You can watch that if you want to know more. Roughly, we got over 50% of the population have had actually the mRNA vaccine. And yet the outcome has, by almost all accounts, been more positive than perhaps we would have dared hopes in earlier days, particularly when you're sending a vaccine, a new technology on such a scale now, with billions of people, at least over 2 billion people having their first dose. We're going to see real quick if everybody starts turning into, radioactive monkeys. Of course, I'm being silly here, but majority, 90% generally of the side effects noted in vaccines are seen within the first 2 to 3 months, particularly the first 6 weeks. So we will see over I know it's been 6 weeks already for many people, but we're going to see over the next 6 to 12 months the potential short-term and long-term side effects that could present as a result of this mRNA technology in different populations who predisposed to more side effects than the other. Does this make it more risky than getting the coronavirus? Right now, it doesn't seem so, especially from a perspective of side effects from a vascular perspective. Even if we compare blood clot risks, which is like a 0.02 risk based on the Australian statistics I looked at 3 weeks ago from the health government website. Is about a 0.02% risk of blood clots as a result of getting the AstraZeneca vaccine, which is not a Pfizer vaccine, by the way. Now, the risk of getting blood clots from the coronavirus, we're looking at around 7%, with pulmonary embolism being about 11%. Now, that's a UK study, but we can still kind of cross-relate at least some of the data. Of course, it's not population-specific. However, we can generally see between 0.02% and 7 and 11%. Of course, I'm like, okay, 11% of what? How many people? What's the population? Of course, I understand the limitation of the statistics I'm purporting, but generally, the totality of evidence appears to point in the direction that the risk of getting the coronavirus is particularly higher than the risk of getting the vaccine, at least at this point in time. But however, that may change, and I'm not married to any specific point of view. I don't really care. I would like everything to be healthy and safe, because why wouldn't I want to live in that society where my family, friends, and peers can prosper? I don't want to live in a sick, unhealthy society, although that seems to be more the prevalent thing nowadays, and I don't want it to be exacerbated by vaccines or a virus or this and that. So please know that there's no agenda for me to see either side besides health. Can I be on the side of health? Everyone's feeling and performing well. I'd like that one. So it seems to be at this time. Now, there's more we don't know. I'm open to all evidence from all sides. Please present it to me if I'm missing something, or if there's something else interesting that I may have not purported or seen that could be valuable. But looking at the people like Dr. Rhonda Patrick, interviewing people like Dr. Roger Seaholt, I messed up his name, I'm sorry, and the totality of evidence and research from all these different clinical trials, it seems to be the benefits outweigh the risks, at least at this time. However, you should consider your own specific context and individual risk factors, comorbidities, population, environment, etc., in making an informed decision. But I hope this type of information helps people generate some critical thinking and logical reasoning behind the decisions they're going to make for or to postpone or to forego a vaccine at all. So I hope that was valuable. I will keep putting these out as we learn more, because I'm obsessed with learning more. You got the AstraZeneca vaccine. Have you seen the research? Is it safe? Is it efficacious, particularly compared to the Pfizer mRNA vaccine? Because we have to remember there are two different types of vaccines, one being a chimpanzee adenovirus, being the AstraZeneca, one being an mRNA virus, which have different modes of vector and transportation into the body. So we're going to go through the safety and efficacy of the AstraZeneca vaccine based on the current literature research that we have now. So we had a pooled analysis of 4 studies that found a pooled analysis. So we're taking 4 studies, 4 randomized control trials, and we are analyzing the data together and comparing. So we found that 2 standard doses of the AstraZeneca vaccine, the overall efficacy was about 70.4%. Now, when we compare that to the Pfizer, if you've looked at previous videos I've made on this stuff, the other vaccines, the Pfizer vaccine had about a 95% efficacy, which is quite a bit of difference at producing immunity to handle the coronavirus. Now, several months later, AstraZeneca announced it was 76% effective at preventing symptomatic disease. That was in March 25. Now, that is from a press release from AstraZeneca. Of course, they would want to make their vaccine seem more favorable than it is, so that's their bias. But I'm going to show you two. One, a pooled analysis clinical trial, and what AstraZeneca has recently said. However, what's really strange is that it is dose dependent. It's really important. If you get a vaccine, you should understand what dose you're getting. Ask the nurse or the doctor who's administering it. And if they don't know, I'd be very concerned because dose makes the poison and the medicine in anything. So what we actually saw, surprisingly and strangely, is that the lower dose in these clinical trials were finding they had better efficacy. It was a lower dose was better at producing and preventing symptomatic disease. We don't know why. We need more research, right? But if you're getting the AstraZeneca vaccine, this is something to consider. If you have any control over the type of dose that you're going to get, you may want to consider getting one that represents the dosage in this clinical trial that had a higher efficacy versus a higher dose, which seemed to have a low efficacy. So the method of this, now, if you could just stop right here and it's like, okay, cool, I'm done. If you actually want to understand the research of it and kind of critique it with its validity and reliability, the method, we had 4 ongoing blinded randomized control trials across UK, Brazil, South Africa. Participants 18 years and older, randomly assigned to either the AstraZeneca or control, which was meningococcal vaccine or saline. The findings: between April 23 and November 4, nearly 24,000 people were enrolled. They received 2 standard doses. Vaccine efficacy. See, what I reported before, that is mean. That's the mean. That's the average. What we need to understand are confidence intervals, which is the interval of efficacy that we are 95% sure. The confidence interval is between 41% and 75%. That's relatively large range. And you can be one of them. We have to understand averages do not represent individual responses. Averages represent population data. Just because you're an individual, I'm an individual, we're going to fall somewhere in that spectrum, and we have no idea whether we're going to fall high, middle, or low. You could be a low responder, and you might need a higher dose or a lower dose, or you might get that vaccine, but it might not be efficacious to you. You might not produce enough antibodies to prevent symptomatic disease. Participants who received the lower dose followed by a standard dose, that's very specific what I said. I said lower dose before. Now specifically, the findings were participants who received a low dose followed by a standard dose, not low dose, not high dose, standard. So we have standard, and then we have, which produced the results around the 70% mark. Now we have low dose, standard dose, produced efficacy in the 90%. However, the confidence interval was 67 all the way to 97%. Again, a large range that we can expect to see with early vaccines and things where they're so finicky, like the immune system. Everybody has a different immune system mediated response. It can be, oh my God, do you know how many variables are involved in building antibodies and responding to a vaccine? If you are sleep deprived the night before you get a vaccine, you will respond dramatically worse to getting a vaccine, to building antibodies, than if you were well rested. I'll do that video on that later. But Matthew Walker, type it in. If you want to know more, just type those keywords in. It's staggering. Anyway, overall, the efficacy was 70.4%. Okay, 21 days after the first dose. Now let's talk some side effects, or just like potential, because guess what, guys, you can get COVID from a vaccine. As it can happen. You're not just building antibodies, you can then become symptomatic. 10 cases were hospitalized for COVID-19, all in the control arm. 2 were classified as severe, including 1 death. There were 74,000 person months of safety follow-ups over 3.4 months. So they're doing follow-ups, watching side effects, and they were testing, I believe, antibody responses. 175 severe adverse events occurred in 168 participants. So some people had, that might be weird for some people. Some people obviously would have had 1 or more adverse effects, because your adverse effects are higher than participants. 168 people had adverse side effects, adverse events, 84 in the AstraZeneca, 91 in the control. When we're talking about a 24,000 person study, relative risk is important, absolute risk is important. This is relatively quite low. Interpretation. What do we make of all this between the findings and the efficacy in the low dose and the high dose from these pooled analysis of the safety and efficacy of the AstraZeneca against SARS-CoV-2? Is it appears to have an acceptable safety profile and has been found to be efficacious against symptomatic COVID-19 in the interim analysis of ongoing clinical trials. Now, this is where human interpretation comes into point. It depends on how you define acceptable and how you define efficacious. If I say compared to what? If I compare the efficaciousness of the AstraZeneca compared to a Pfizer, I would opt for the mRNA vaccine, which has more consistent, robust efficacy in regards to reducing symptomatic disease and building an antibody response. It has a small confidence interval. It has high efficacy, and it's a newer technology that gives me more confidence towards its innovation. And once I understood how mRNA worked, the difference, it doesn't actually enter the cell. It forces your body to make the protein itself instead of injecting the protein into the cell. Okay, there's some of the differences that may seem attractive to some people, and so you may want to opt for one over the other based on the totality of evidence and different mechanisms behind each vaccine, or you may be perfectly content with the efficacy of the one you got because you realize maybe that's okay, I just want to cover myself now and manage my risk, and moreover, this may turn into a routine thing, and I may be perfectly comfortable getting this, twice a year, once a year, routinely every single year. So again, individual risk analysis is really needed depending on your environment, context, comorbidities, health, situation, which we must all respect. At least I will respect. I just want to put out the information so more people are aware of the research literature and they're not headline reading shit like this. Evidence suggests AstraZeneca and Pfizer equally effective. Anastasia Titsakis on the 11th of May 2021 on News GP. That is incorrect. You have incorrectly observed the data because these headlines like this mess me up because they're not the same. They're not equally as efficacious. Even if you look at the low dose, high dose, even if you quote different research, the research that often gets cited when people say this, and I looked at the research, it was not one research study that people may look at, the impact of vaccination of SARS-CoV-2 cases in community, a population-based study using UK's COVID-19 infection survey. It's a preprint, wasn't peer-reviewed, means hasn't been evaluated by other professional other researchers. Study, 370,000 UK participants, 16 years or older, 1.6 million PCR tests, and they noticed odds of new SARS-CoV infection were reduced 65% since first vaccination with no second dose versus unvaccinated individuals with evidence of prior infection. So obviously, yes, getting a first dose vaccine is going to reduce the chance of getting an infection by 65%. Cool, yeah, okay, cool. I assume that. Then they purported there was no evidence that these benefits her article purported there is no evidence that these benefits varied between Oxford, AstraZeneca, and Pfizer. However, the p-value was 0.09. Anybody remember what a p-value is? P-value is a measure of statistical significance. Basically, that means if your study and statistic is statistically significant, there is less than a 5% probability that the results that you found are due to chance or randomness. Random chance. Less than a 5% probability. In order for that to happen, you need a p-value of 0.05. 0.05. This study here, a p-value of 0.09. And even close to 0.05. So we cannot say, if you don't have statistical significant claims, you cannot claim that evidence suggests AstraZeneca and Pfizer are equally effective, because it does not suggest that in a non-peer-reviewed preprint that is not a statistically significant claim. That just Peter Griffin grinds my gears, man. What can I say? Because people are going to read that. I don't know how many people read this. People be like, oh, it doesn't matter what vaccine I get. No, it does matter. It does matter. Based on the evidence so far and the current technology and innovation and research that we've done so far. It does seem to matter if you care about efficacy and the mode of transport and the side effects. And just good science. Just read, please read science. Just please. I'm driving myself crazy. And look, I might be wrong on some shit one day too, like this, right? I might slip up and be like, oh shit, I misinterpreted. It's not statistically significant. I'm a mess up, but no, it's not against the individual. It's just against bad reporting. I'm writing articles that a lot of people are going to read and then to make decisions on. Like, I'm going to sit here for an hour. I've been sitting here for an hour doing these videos. I'm just nuts. What am I doing? Why don't I do some shit? What am I doing out here? What am I doing out here is a drive for the truth. I just want to do the best job possible at finding the closest thing to the truth. Because there's so much misinformation, disinformation, errors of judgment, irrational, illogical thinking, lack of critical thinking with such important topics like this within human science. I want to suffocate that, put it in a bag, throw it out, light it on fire, and then deliver this instead, So please take that into consideration when you read sensationalist headlines, and don't just read headlines, look into the research being purported. And you might very well save yourself in a lot of ways and be able to live a healthier, more effective life and make more informed decisions. Better information makes for better decisions.